Ribs can be very difficult for students as there are many variations and different protocols at different clinic sites on how to go about doing these. For our purposes, we are going to use our textbook instructions and goals and what we've been going over in class. What you're looking at right here is a PA projection of above diaphragm ribs. Now, what we have to understand is why we do a rib series, either PA or AP. Remember, a PA rib series or PA projection is for anterior ribs. An AP projection is for posterior ribs. Why does this matter? Well, our goal is to get the area of interest closest to the IR. So as we talked about in class, we have step 1 is to identify the area of pain, and we said that this was going to be anterior, so we will do a PA. Anterior, because we want the anterior ribs closest to the IR, and that is what our PA does for us. We'll talk about the the third step when we do oblique ribs. But let's take a close look at this. What's important about positioning for our AP PA above diaphragm ribs? Well, you need to have no rotation, and that's very similar to a chest. We're going to look at our SC joints, and we're going to look at the midline here. Are our lateral rib margins equidistant from our midline, and are our SC joints equidistant from midline? This is a good indication for rotation. Next question we need to ask is, do we have the entire first rib visible? And in this case, we do. We can see it right up here in its entirety. This is important because this is going to help you accurately count the ribs, because in above diaphragm ribs, we would prefer to see ribs 1 through 10 above the diaphragm. That is ideal. Now remember, if you have a patient with a fractured rib, you're not always going to get the ideal because they can't take that deep inspiration that we need to lower the diaphragm and get those ribs above the diaphragm. So 9 is also acceptable. Ribs 1 through 9 is acceptable, and even 1 through 8. But remember, you must include 8 on your below diaphragm ribs. So here you see we've got ribs 1 in their entirety. Here's 2, 3, 4, 5, 6, 7, 8, 9, 10. We also see 11, and we see 12. I'm going to outline our diaphragms in blue. So here is our right hemidiaphragm, and here's our left hemidiaphragm. Okay, and as you can see, we have ribs 1 through 10 above our diaphragm. It's important for you to be able to understand how to count ribs, and as you could see with the drawing, I was able to follow them all the way around. Now remember, I'm going to change my ink color here. Remember, your posterior ribs go like this. Here's a posterior rib here. Here's a posterior rib here. Your anterior ribs are going to come more down, like if you're putting your hands down in your pockets, more of a downward angle like this. They're going to be in the front. So this is posterior ribs come across this way. Anterior ribs are going to angle downward like you're putting your hands in your pockets. Thanks, Mohammed, for that tip. Remember, in a rib series, we want to have a little bit more of a higher contrast. We want to see more black and white than what we would in a chest x-ray. In this image in particular, I think we need to drop our KVP a little bit more and see a little bit more contrast. And here's why. when we're looking at this image, especially right through here in the heart shadow and lung markings and over here, it's very difficult to see rib fractures. They are not the easiest things to find. We start to lose bony trabeculae and sharper rib margins. We could still see them, we could still outline them, but we're starting to lose some of that detail when we get into the middle of the heart shadow and these lung markings, especially right through here and here and here and this rib as well. We don't really care about anything down here because this is an above diaphragm PA projection. We would get more of this when we do our below diaphragm ribs. So in order to get a more black and white contrast, in this image in particular, I would lower my KVP to improve contrast. Think thoracic spine technique versus chest technique. Now remember, we've already completed step 1, which is identify the area of pain. So we're going to cross that off of our list. Step 2 was to get this area closest to the IR, which we just did in our above diaphragm ribs. Anterior injury or pain is a PA projection. Posterior injury or pain is an AP projection. So we've completed successfully step 2. Now stop right here. Stop here. Don't think about area closest to the IR anymore. You're going to confuse yourself. You've already accomplished goals 1 and 2. We're going to move on to step 3, which is going to be how do we determine which oblique to do. Well, our goal of step 3 is to move the spinous processes out of the way of the affected area. So take a look. If a patient is PA, which is an anterior injury, we're going to look at this projection in the top image. I'm going to pull it over this way and enlarge it so we can see it better. If we are looking at an anterior injury on the right side, our goal is to get these spinous processes out of the way and we move them towards the left, which puts our left anterior side closest to the IR, okay, because our patient's already in a PA position. Moving the spinous processes out of the way puts our patient into a left anterior oblique position, and our right side ribs are now elongated. So this gives us an LAO, gives us a good picture of our right anterior ribs. Now you can see I highlighted the ribs here in green just so you could look at the right side. I know they're posterior, but y'all just have to get over that little fact there. We're looking at anterior right-sided ribs, so we are doing LAO. Likewise, if we are going to, and I've pulled up the RAO position here, if we are doing anterior, my pen, anterior ribs of the left side, which would be these guys here, okay, we want to get our spinous processes out of the way. So we're going to move the spinous processes towards the right, which means our patient's right side is now closest to the IR, giving us an RAO position and elongates the left-sided ribs. Okay, so we were in a PA position. We moved our patient's affected side away from the board, our spinous processes away from the side of injury, and it resulted in a right anterior oblique. So remember, going back to this, what we just did here, hold on, get my pens. If a patient is PA, we have a right side injury, we're going to do an LAO. If we have a left-sided injury, we're going to position our patient RAO. As you can see, I've deleted our RAO and LAO positions, and that leaves us with our RPO and our LPO positions, which means if we have anterior, get my pen, if we have, posterior injuries, because we just did anterior, we're done with those. We have posterior injuries. We want to elongate that side of interest. Then we're looking at the right side. Start with the right side. We're going to move our spinous processes again away from the site of injury. Okay, move them out of the way, which elongates the right-sided ribs. By moving these spinous processes away from the site of interest, we've put our right side closest to the IR, and we are in an AP. We're originally in an AP position. We've moved the spinous processes away from the site of interest. I know I'm being repetitive, bear with me. That elongates our right-sided ribs and puts us with our right side closest to the IR, which is an RPO. So an RPO for right side posterior injury. The opposite of that would be our LPO. We've moved our spinous processes away from the site of injury, which is our left. We've elongated the left. And by moving these away from the site of injury, we've put our left side closest to the IR, which gives us an LPO position. Okay, we originally started in an AP, which means AP towards affected side towards the IR. A PA is the affected side away from IR. And these are obliques only. That's why I tell you to stop at step 3. Move that out of the way and that out of the way. Remember, if you start thinking too much about closest to the IR, hold on, that's step 2, because it comes the opposite, step 3. We are worried about getting the side of interest elongated and the spinous processes out of the way. So what will this look like? Well, here you go. What we are looking at, which is nicely marked for us in these images, is an LPO and an RPO. Here's our right marker. Here's our left marker. So if this is LPO, it means our left-sided ribs, left axillary ribs, are our main interest here. We've elongated the left side. Our patient has their left side closest to the IR, and these spinous processes have been pulled out of the way so that we can see these nice elongated ribs. Again, this is above diaphragm. We would like to see ribs 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 above the diaphragm. We can still see 10 coming through here. We definitely have 9, so this is certainly an acceptable image. Keep in mind that you then LPO, where's my pen? LPO and RAO will look very similar on an X-ray. The differences are so subtle in these images that you will most likely not be able to tell which is which. So on the test, if we are looking at left side, we have left side elongated ribs as marked by our anatomical marker. You could write LPO/RAO oblique above diaphragm ribs. That would be the answer to that test question. This case, we have right-sided elongated ribs. And this is again marked RPO, so RPO, in this case we know what it is if it's marked, but if it's not marked, we can not really tell the RPO versus the LAO. So I would want you to use this as your answer. For this projection, whoops, moved the thing. Let me get my pen. For this projection, your answer would be RPO/LAO above diaphragm ribs. Now, what about our positioning criteria? How do we know we have the correct obliquity? Let's look at this LPO here on your left side of your screen. All right, we have elongated left side ribs, so that's a good indication that we've done the right thing. We've obliqued our patient enough. Erase these real quick. Another thing that you can look at is the location of the sternum. Now here we can see the tip of the manubrium here. So we're going to assume that our sternum's laying right about this area. We don't see it very good, and that's perfectly acceptable for a oblique rib projection. But you can guesstimate of where it might be. So if you guesstimated, the xiphoid tip is going to be right here in between the vertebrae and the lateral rib margin, which is a good indication of correct obliquity. The other thing that you want to look at, and let's look at the RPO for this example. I'm going to zoom in just a little bit here. Okay, come over here and use our pen. Now, you can see little pedicles here. Now remember, on an AP thoracic spine, we can see both pedicles, like a little bird face, right? If you start to see both pedicles on these vertebral bodies, like you would in an AP T-spine, you have not obliqued enough, because then it starts to look more like an AP. Let's look at the sternum in this image. Well, here's the ends of our clavicles here. So our sternum's going to be right about here. Okay, we don't see the sternal angle too much, but look how close this sternum is to the spine here. Okay, there's not a lot of distance. I personally, as a technologist, would have rotated this patient a little bit more. They don't appear to be quite 45 degrees rotated. We do have some elongation. I'd like to see a little bit more, because you still have all of this up here yet to be seen in a nice elongated projection. So this RPO, although nice and clear in technique, I would have liked to have seen a little bit more elongation of these upper ribs, so we can see more of the axillary side, because remember, that is our main area of interest. If you look at the LPO, the obliquity here is a little bit better than I think on the RPO. Both would be fairly acceptable, but just if you had to repeat them for any reason, maybe oblique your patient slightly more. If you have obliqued too much, well, what does that look like? Remember, in a lateral T-spine, you start seeing open IVFs. If you start to see open IVFs back here on your T-spine, you have obliqued your patient way too much. Also, if you start to see the sternum projected more out here, like if you are doing a lateral chest x-ray, that's another sign of over-rotation. I'm going to call that it for the day. I could not find any images for below diaphragm ribs. The only thing I could tell you to remember there is to make sure that you have ribs 8 through 12 included. You're taking these images on expiration, which pushes the diaphragm up, and you should be able to see ribs 8 through 12 through the diaphragm. And that's going to give you a good indication of whether you have the technique or not, is if you can follow the outline of those ribs through the diaphragm. Also remember that on below diaphragm projections, you will always do those AP. If you can do them supine, that's even better, because that flattens the abdominal tissues and organs so that you can penetrate more through those organs and tissue to get a better detail of ribs 8 through 12. You will also do oblique below diaphragm ribs. And again, since you're doing AP, starting with the AP position, you will only do an LPO or an RPO projection for the ribs. Just follow your oblique instructions there. Again, it's 45 degrees. obliquity. Same rules apply, something that can help you in below diaphragm ribs, and whether you've got the correct obliquity, excuse me, I'll grab my pen again, is look for the Scotty dogs in the lumbar spine. If you have your Scotty dogs, you've got a good 45-degree angle. If your lumbar spine is starting to look like a lateral L spine, you've over obliqued your patient. If they're starting to look like an APL spine, then you've under obliqued your patient. I guess the last thing I have for you today is remember on our test next week, you can have just a unilateral side. So if you get a unilateral image, make sure that you write that in the projection name. So if this were the unilateral that we had, you would write RPO/LAO above diaphragm unilateral ribs. That's all for now. We will catch you next week. Good luck.